Good evening, everyone. Thank you so much for joining us for tonight's presentation, Pandemic Perspectives, What We've Learned About COVID-19. The webinar is scheduled to begin at 7 o'clock, so in approximately 10 minutes. We hope you're all enjoying a lovely evening, and we'd sure like to know where you're joining us from. Down at the bottom of the screen there, you'll see a chat box, which is now open. If you care to, please enter your city where you're joining us from tonight. We have over 800 people who've registered for tonight's event, so we'd love to see just exactly where people are joining us from. Make sure that your setting is set to all panelists and attendees, and that way everybody can see where we're all joining from. So it looks like we have people from Nanaimo, BC, Palm Desert, California, that sounds heavenly right now, Canmore, Calgary, lots of people from Edmonton, Sherwood Park. So again, we are here tonight for Pandemic Perspectives, what we've learned about COVID-19. We're looking forward to a fantastic panel discussion with some leading experts on COVID-19. There are some pre-submitted questions that we've had, but we will have the Q&A box open throughout the presentation, and you're welcome to submit a question at any time. Again, our chat box is open there, so if you'd like to let us know where you're joining us from tonight, that's always fun to see. As I mentioned, we have over 800 people registered, so we always like to see where our alumni and our guests are joining us from. Of course, tonight's event is only one event that's part of our Alumni Weekend lineup. Alumni Week this year, of course, is all virtual. This is the first time that we've had to go entirely virtual, and it's working out really well. We've got some fantastic programming that you're invited to take part in, a number of virtual tours that you can log on at any time and take a tour of our W.G. Hardy Classics Museum, for instance. You can tour the Anne Lambert Clothing and Textiles Museum. The Faculty of Science has created several tours of their museums as well. Take a look at the paleontology lab, for instance, and see all the dinosaur bones, the story of paleontology at the University of Alberta. So lots of stuff available online for you to check out and see. And I'll just get Katie maybe to put up the link for our Alumni Weekend site. I see we have Roseanne from Uxbridge, Ontario. Thanks for joining us tonight. Again, if you're just joining us, we have our chat box open, so you're welcome to leave us a message there. Let us know where you're joining us from tonight. We're going to start the webinar in about 6 minutes, so you've got some time to grab a glass of water or perhaps a glass of wine if that's what you like. We have Clara who's joining us from Brazil tonight. That's fantastic. Welcome, Clara. Who else have we got that's from outside North America? I suppose it would either be late at night or early in the morning if you are joining us from overseas. Oh, Susan from New Jersey, welcome. It's always fascinating to see where people are joining us from. Of course, that's one of the benefits of our virtual Alumni Weekend this year, is that people from all over the world can join us. You don't have to be here on our campus in Edmonton. So again, welcome to those of you who are joining us for tonight's webinar. We'll get started here in about 5 minutes. And of course, this is the presentation, Pandemic Perspectives, What We've Learned from COVID-19. We have a fantastic panel of experts who've joined us tonight, and I think you're really in for an outstanding conversation. Lots to learn from this group. Thanks again to everybody who's putting their location into our chat box. So far, Clara is the winner. She's in Brazil, definitely the furthest away. We have Pat from Edmonton. Thanks for joining us tonight. What degrees do some of you have? If you're an alumna or an alumnus of the University of Alberta, what faculty did you graduate from? It would be interesting to see if tonight's audience is primarily health specialists or commerce students. Let us know what degree you achieved at the university as well. We have a nursing grad. Oh, there's Bill Chung. Hello, Bill. Susan is a registered dietitian, nursing. Emily Hoffman from the Faculty of Medicine and Dentistry. Hi, Emily. Arts and science, sociology, medical doctors, health science, education. It looks like we've got a lot of them. A PhD in French. Bonsoir, Vivienne. Amber's joining us from Vancouver, but says she misses Edmonton. It's been a beautiful week here. The River Valley is covered in green and gold. It's just a perfect couple of evenings that we've had. Terrific time of year here in Edmonton. So we're going to get started in about 3 minutes. Just waiting for more of our attendees to log in. So again, if you are just joining us, we have our chat box open. You're welcome to enter the degree that you've achieved here at the University of Alberta, or perhaps where you're joining us from. So we have Fritz down in the Crow's Nest Pass. That's a lovely area of the province. Judy is in environmental sciences. Thank you for joining us tonight. Hello to Stephanie in Seattle. So lots of cities represented, lots of degrees as well. Several people joining us from Edmonton. We have Kelowna. Hopefully the smoke there has dissipated, Pat. I hope it's a lovely and clear evening there on Okanagan Lake. Biomedical engineering, Kathy is also an engineer. Or I guess that was Brian, sorry. We've got people from Calgary. Camrose, lots of people, lots of alumni and guests joining us from around the world tonight. So that's wonderful to see. We'll get started here in just a minute. I know our panelists have lots of great information to share with you, so I don't want to cut them off and cut their time short. They're the ones that you want to hear from tonight. So thank you again to everybody who's joining us for this evening's presentation. We're looking forward to a really fantastic evening with our panelists. Again, this is the Pandemic Perspectives webinar, so if that's what you're looking for, you're in the right spot. I know that there's also a business webinar tonight, so if that's what you're looking for, you're going to have to try a different room. Caroline is joining us en route. She's on the QE2 right now, so drive safely, Caroline. Okay, just a minute here and we're going to get started. So once we begin the webinar, we will close down the chat box. So just a couple more minutes to let us know where you're joining from and before we get ready. We'll give it another 30 seconds here. We've still got lots of people joining us. Hello to Christina in Ottawa. Okay, I think with that, Chelsea, we're going to get started. So we're going to close down the chat box. Okay, thank you everybody for joining us for tonight's presentation, Pandemic Perspectives, What We've Learned About COVID-19, featuring researchers from the U of A's faculties of Medicine and Dentistry, Nursing, and the School of Public Health. My name is Colleen Elliott, and I am the Manager of Education and Special Events in the Office of Alumni Relations. We acknowledge that the University of Alberta is located on Treaty 6 territory and respect the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. we want to acknowledge and thank our affinity partner and sponsor for tonight's event, Manulife. Tonight's program will begin with each of our panelists speaking briefly about the work they are engaged in response to the COVID pandemic, what they've learned, and what the immediate future might hold. Afterwards, Dr. Lawrence Richer will moderate a discussion with the entire panel, giving us the opportunity to learn more about the work being done at the U of A and further insight from our experts. To conclude the evening, our panelists will have approximately 15 to 20 minutes to answer some of your questions. Although the chat box will remain closed during the presentation, you may submit your questions throughout. Simply type your question into the Q&A box, which is likely at the bottom of your screen, and our panel will have an opportunity to address some of them. I would also like to acknowledge a special guest in our audience tonight, Mr. Tyler Hansen, the President-elect of the U of A's Alumni Association, is joining us for tonight's panel. Thank you and welcome, Tyler. And now it is my pleasure to introduce our extraordinary panel of experts. Dr. D. Lauren Terrell holds 2 degrees from the University of Alberta, is a distinguished professor at the university, and is the founding director of the Li Ka-shing Institute of Virology. His research on viral hepatitis resulted in the licensing of the first oral antiviral agent to treat chronic hepatitis B infection in 1998. From 1994 to 2004, he was Dean of the Faculty of Medicine and Dentistry. He is an officer in the Order of Canada, a member of the Alberta Order of Excellence, a Fellow of the Royal Society of Canada, member of the Canadian Medical Hall of Fame, and a Killam Prize winner. Since COVID-19 began, his lab has been active in SARS-CoV-2 research, and he is currently serving on the Government of Canada's COVID-19 Vaccine Task Force. Dr. Carol Estabrooks is a 2-time alumna of the university. She is a professor and Tier 1 Canada Research Chair in the Faculty of Nursing. She is a member of the Order of Canada and fellow in both the Canadian Academy of Health Sciences and the American Academy of Nursing. Just this year, Dr. Estabrooks was elected as a fellow to the Royal Society of Canada. She is scientific director of the Pan-Canadian Translating Research in Elder Care, a research program at the University of Alberta, which focuses on improving quality of care, quality of life, and quality of end of life for older adults in nursing homes, and quality of work-life outcomes for staff. Dr. Dean Urich has received 2 degrees from the U of A. He is a professor and program director for the Clinical Epidemiology program within the School of Public Health. Provincially, he is a joint lead, career development in methods in health services research, platform for Alberta's strategy for patient-oriented research, support for people, and patient-oriented research and trials unit. Nationally, he is the chair for the Personal Awards Committee and board member of the National Research Council of Diabetes Canada. He was elected as a fellow to the Royal Society of Canada under the College of New Scholars, Artists, and Scientists in 2018. His current focus is on health outcomes in patients with chronic diseases, as well as quality improvement initiatives with several First Nations communities in the province. Dr. Lenora Saxinger is an infectious disease specialist whose work has focused on antimicrobial stewardship and resistance and improving surveillance. She is an associate professor of medicine in the Faculty of Medicine and Dentistry and medical lead of antimicrobial stewardship for Northern Alberta with Alberta Health Services. Her work includes education, policy development, and knowledge translation in medical and other healthcare professional training. She is currently co-chair of Alberta Health Services COVID-19 Scientific Advisory Group. Finally, our moderator, Dr. Lawrence Richer. Dr. Richer holds 3 degrees from the U of A. He is a Vice Dean Research in the Faculty of Medicine and Dentistry. He is also professor in the Department of Pediatrics and pediatric neurologist with clinical and research interests in the treatment of headache and disorders of the autonomic nervous system. Dr. Richer has worked to maximize the use of health data to improve patient outcomes through research and to enhance support for innovation in clinical trials. As I said, this is an outstanding panel of experts, so we're in for a special evening. With that, I would now like to invite our first panelist, Dr. Tyrrell, to start us off.
Thank you very much, Colleen. That was great. Ladies and gentlemen, it's very nice to see you again in the alumni event. It's always one of the nicest weeks of the year. It's very different this year, unfortunately, because of the pandemic, and we're having to do this virtually. Let me say that I, as a virologist, often worried that we might have a pandemic, and I often thought it would be caused by influenza, a severe form of influenza. However, we have been surprised, and maybe we shouldn't have been, because we did have MERS and we did have SARS-1 that warned us that coronaviruses could cause a pandemic, and we are experiencing it now. Let me first thank the alumni. I made an appeal for some funding to help us with some of the research at the University of Alberta through a COVID-19 and emerging viral infectious diseases. You responded very well. We received over $200,000. We advertised widely throughout the whole university, and people from all faculties could apply. And we had 33 applications. We set up an adjudication committee and have awarded 6 excellent research projects. They range from projects looking at the masks and how we can sterilize the virus within masks, to screening new antiviral agents, to developing better vaccines. And I want to thank you very much for your generosity. Secondly, I want to say that you should be proud of the University of Alberta, and I'm very proud of how the university has done on 2 major calls from the Canada Institute of Health Research. The Canadian Institute of Health Research is our major funding organization from Canada. And in the first call in March, the University of Alberta finished top of all the institutions in Canada with the largest number of research grants and the largest number of funding. About 2 months later, there was a second call. And once again, the University of Alberta did very well in the second round with 18 institutions, and we finished 3rd. I just want to mention that to you because I'm very proud of how the university has responded, and I think you will as well. Many of these grants have been in how we improve vaccines, develop new antivirals, in the social sciences, how do we care for our elderly, how do we handle school opening closings, how does the effect on children who are not in school, the genetics of how the virus changes, and new diagnostic approaches. I'm very pleased to see how rapidly and the university has responded to this request. I have been very privileged to have been asked to serve on the vaccine task force to advise the government on selection of vaccines. Let me say that there are 3 people at the University of Alberta that are national task force advisory committees. The Therapeutics Task Force has Matthias Gote, the chair of the Department of Medical Microbiology and Immunology, and the Immunity Task Force has Dr. Yuta Prixitis, Professor Emeritus, on serving from the University of Alberta. I would like to say that our work on the Vaccine Task Force is to advise the government on what can be the safest and most effective vaccine, and how do we in Canada get access to these vaccines in a timely manner. I must say that it's very important to understand how critical it is that vaccines are safe. There's a difference between antivirals and vaccines. Vaccines are given to healthy people, and we're trying to vaccinate as many people as we can. So when you go out to mass vaccination globally, you must have extreme safety. The other thing is it must be effective as possible, and we don't want to be at the back of the line. So we're advising on how we can get there. I would also say that antivirals are extremely important, And antivirals are used differently because they are only used in people who are ill with the disease. So there you can often look at a balance between the benefit of the antiviral and the disease. So you have a little more risk tolerance with antivirals than we do with vaccines. There are two, I just want to stress though how important antivirals are. There are two diseases that you all know about that we've never been able to create a vaccine for. Number one is HIV/AIDS. We're still trying, but have not been able to do this. And number two is the hepatitis C virus. However, in both of these diseases, antivirals have been developed that are extremely effective and cure hepatitis C and suppress the disease in HIV/AIDS so people live a normal life. I would like to say in my own research, I have been fortunate to work with some excellent people, Joanne Lemieux in chemistry, John Vetters in chemistry, Joanne Lemieux in biochemistry. And we have been working on trying to develop a very specific antiviral for one of the enzymes within the COVID-19 virus. It is a clear target, and we've had excellent results and have just published the paper in Nature Communications. That is a highly cited journal already, or the article. And we have worked with a company that has access to this particular antivirus, Navi, and we have been successful in getting a grant to take this new antiviral agent into patients. And we will start the clinical trials in this fall. I want to thank Dr. Eileen Schwartz from Infectious Diseases, who will also assist with this study. These are the things that I've been involved in, and I'm very excited about the research that's gone on at the University of Alberta. I think that as alumni, you can be very proud, and I'm sure you'll hear more about University of Alberta research from some of our other guests. At this point, I'm going to ask Carol Esterbrook to speak next and hear from Carol on some of her work. Thank you very much.
Great, thank you very much, Lauren. I want to also thank the organizer for participant list, a number from my own discipline. As I said, I'm very pleased to be here, but I'm deeply saddened by the topic that brings us together this evening, in particular because my work is exclusively in long-term care. So I've been in long-term care for over 15 years now, focusing, as you heard, on quality of care, life, and end of life for seniors in nursing homes, and quality of work life for the frontline staff, in particular, the care aides, orderlies, personal support workers. They're called different things in different parts of the country. Our team is large, it's pan-Canadian and international in nature. And we're focused not just on those areas that I've described, but also on trying to find practical solutions to deal with gaps and problems that arise, some of which have been there a long time. As you all know, COVID-19 has had a profound and catastrophic impact on long-term care. As of just yesterday, Canada had over 7,000 deaths from COVID-19 in nursing homes. That represents 77% of reported Canadian COVID deaths in total, the highest rate in the world. So unfortunately in this area, Canada has a national shame with which we must deal. I've done lots of things, as have all the other panelists, over the last 7 months of the pandemic, but I just want to talk about two that I thought might be of interest to you. The first is my team is continuing work that we've been involved in and now preparing to undertake an assessment of the impact of COVID in nursing homes. So we're going to be going to the field, although in a very dramatically altered way, in late 2020 and in 2021, to assess the impact on both the residents and the staff. I mean, we know the impact has been severe, particularly in facilities with major outbreaks, but we need to look across the system as a whole at impact at all levels and really get some evidence with which to examine the effects on staff and residents, not just so that we can describe it, but so that we can design solutions to deal with areas that are in most need. We know from studies in the SARS epidemic some years ago and early reports out of Wuhan, China, and other centers that staff, frontline staff in all settings have and can be expected to experience stress symptoms, insomnia, anxiety, depression, and in some cases PTSD. So we're going to be, as part of our assessment, looking at stress responses, as I've described, as well as well-being and job satisfaction and burnout in frontline staff. And we're going to be adding new areas that we determined from interviews that we'll do this fall and winter with care aides and managers. So that's the underlying ongoing work. The second major thing that's occupied a lot of my time this summer was a report that I chaired for the Royal Society of Canada entitled Restoring Trust, COVID-19 and the Future of Long-Term Care. And it looks like this if you're interested. And you can find it on the internet by just typing in Restoring Trust COVID-19 and have a more thorough look that I certainly will be able to talk about. I had just a stellar panel to work with from across the country, very senior people, all of whom have been working in long-term care for a long time. And I would have to say it's one of the few times in my career when so many people with impressive credentials and healthy egos came together and set all of that aside and really worked for a common good and are still working to try and move some of our recommendations to action. So we made first a strong case that COVID-19 did not break the long-term care system. It was broken decades and decades before 2020, and the solutions, therefore, are going to require more than fixing the COVID-19 problem. Second, we handled the pandemic badly in many long-term care sites. Third, that the challenges in long-term care cannot be addressed unless we address our attitudes toward the elderly and toward women and the value we place on caregiving, or in our case, the value we don't place in this country on caregiving. And fourth, this is the good news, we know what to do. This is not a case that we don't know what to do and we need research to tell us what to do. It is the case that we have to mobilize as citizens and governments and make a choice. We have to decide to fix this issue, to transform the long-term care system that is responsible for our oldest citizens at the most vulnerable point of their lives. Also requires that we focus as much attention on social care as we do on medical care. Issues of life quality are measured in social ways: pleasure, connection, absence from fear and loneliness, purpose in life, something to do when you get up in the morning, laughter. And even with very advanced dementia, and about 75% of people in nursing homes have a diagnosis of dementia, and many more have cognitive impairment, even with an advanced dementia, you can live well, but it takes effort and it takes will on the part of the system. So in this report, we made 9 recommendations that I won't go over because it would take way more than the time I've been allotted. But we decided collectively to place the greatest emphasis on the long-term care workforce. We had a problem. There's so much to be done that it started to feel like we were trying to boil the ocean. So we said, where could we get, what's the most urgent area needing attention and resources, and the area that's most likely to bring the greatest relief to older adults? And that's clearly, without equivocation, the long-term care workforce. So we spent quite a bit of time talking about that part of the system. So that's all I'm going to say until the question period. Thank you very much for your time. And I think it's my job now to, and I hope I get the order right, to turn it over to Dean Urich. Thank you.
Thanks, Carol. Thanks everyone for having me here. It's been an interesting panel already, and I hope to add a few things to it. You know, my work around COVID-19 was largely unexpected. And I'm going to give you some of the observations and some of the research that we're doing around First Nations within the province around this area. So as the introduction said, I spent the bulk of my academic time working within First Nations communities in Treaties 6, 7, and 8 across the province to help improve chronic disease care, particularly diabetes. And as many of you are aware, many chronic diseases are suboptimal in First Nations populations. Many First Nations communities are very remote and isolated within the province, and access to the basic social determinants of health, such as healthy foods, adequate housing, and access to medical care is something that many of these communities struggle with on a daily basis. And it's these underlying problems with social determinants of health that really fuel some of the chronic diseases within these communities. So we've developed a number of different programs to try to address these and try to reach out to these communities with different approaches and technologies. But I can tell you that when COVID-19 hit, the entire focus for most First Nations communities switched from a focus on chronic diseases to simply trying to manage the pandemic. Now that said, their public health response to COVID-19 has been remarkable. As some of you may know, most First Nations communities have their own public health units, and they immediately mobilize these units to establish programs aimed at food delivery. Self-isolation centers were set up. They instituted their own testing and own contract tracing within the communities. And as a result, because of this great public health response that they've had, they have some of the lowest rates of COVID-19 across the province and across Canada. And so I do think there are some significant lessons that can be learned about how did the First Nations manage to keep their numbers so low and keep COVID-19 out of their communities. The negative from this tremendous mobilization of resources is that chronic disease care basically has come to a halt in these communities. Most of these communities were already strained prior to COVID-19 due to a lack of health services. And when COVID-19 hit, there really was no extra bandwidth within the communities to also manage chronic disease. As someone who's worked extensively in First Nations communities, it became very evident that there are significant societal, economic, as well as systemic factors that affect the ability of First Nations people to adhere to all the public health directives around COVID-19, such as physical distancing, cleaning protocols, etc. And so in July and August, I partnered with several of my First Nations communities to look at how the community members perceive the public health guidelines, their ability to adhere to these guidelines, and to just get a sense of what the overall impact of COVID-19 is having on them. And so working with the public health units within the communities, as well as First Nations leadership, we developed a number of surveys that we had the First Nations members complete. And I just want to share a couple of very high level metrics with you. I don't have time to go through everything, but over half of the respondents indicated that they had significant difficulties accessing food, clothing, or essential medical care. 25% reported that keeping a 2-meter distance or limiting contact with high-risk people was extremely difficult. As one participant indicated to us, it's not easy to stay home when I have to go to the city for appointments and medical supplies that can take several hours, as well as get food and supply for my elderly mother. From a mental health perspective, we know disparities in mental health exist, with much higher rates observed among First Nations peoples in our country. And our work, unfortunately, also showed this. Fully 20% of First Nations participants are exhibiting signs and symptoms of either overt depression or anxiety because of COVID-19. 26% of respondents stated they experienced an increase in alcohol use or substance abuse issues, and 37% expressed increased concern around their safety or the safety of people with whom they interact closely with during COVID-19. Now, despite all this, COVID has brought some very important positives to the communities and to people, and I want to share some of those stories as well. One person indicated that COVID-19 has allowed them to, self-examine and reprioritize some of their life decisions in a holistic way. They've learned to live a simpler life. One individual indicated that the quality time spent with family has increased immensely. We sit down for meals, we don't run around each night. And one of the older respondents indicated that I'm always really busy with work. And so time at home has enabled me to spend much more time with my grandkids. I've taught them about our history, and I'm teaching them to speak about our language. And so throughout all of this, one of the things that's really been very evident within the First Nations communities is that concept of community and tribal unity. It's really resonated well within the communities, and they've really pulled together to do what's best within their communities, as well as obviously the rest of the province. So all this information has been collected, analyzed, and we presented it back to the First Nations community so they get a sense of how to better understand how COVID-19 is impacting their community members and how they can maybe adapt their public health response to keep their communities safe in the future. And so although the communities have done a great job in terms of their public health response, we clearly have major work to do to address some of the shortcomings around the basic social determinants of health within the communities. You know, these existed before COVID-19 hit, but they've really been highlighted during the pandemic as it's placing these communities at increased risk of just poor outcomes. So moving forward, we want to get a better sense of how COVID-19 is impacting chronic disease care. We know it's causing gaps in care, and we want to see how we can help to close some of these gaps and to make sure that, you know, these communities do not suffer poor outcomes, because we know they're marginalized populations. And when you look across the board, as Carol's already talked about, they are at increased risk of poor outcomes, and we want to try to prevent that. So that in a nutshell is what I've been working on over the last 6 months, and I'm going to hand it over to Dr. Saxinger. Thank you.
Thanks very much. I actually am very interested in the work that you were just describing, actually, and it does kind of intersect with what I'm going to discuss. I'm an infectious diseases physician. I've always been very much a clinician and an educator and a person who works on programs to improve care. And for the COVID-19 response, very, very early on, right around the time of the shutdown, actually, I was asked to co-chair a scientific advisory group and actually ended up advising both Alberta Health Services and Public Health through the Emergency Coordination Center, which is the body that oversees the pandemic response in the province. And what was identified is that people who were at that table trying to make decisions about policies and procedures and clinical guidance and public health guidance really needed to be able to synthesize this vast quantity of always evolving information to make good decisions very, very quickly. And so we had a group come together with quite a wide representation. We would survey the literature, we would look at public health websites, we'd look at unpublished papers, we'd synthesize it in a formal way, we'd have committee discussions about it, and we'd make recommendations, sometimes within 3 or 4 days. I think that we ended up putting together almost 40 rapid reviews of topics that were part of our decision-making process in healthcare in Alberta in quite a lot of different domains. And in parallel with that, I think very early on, it was clear to me that especially when people were in lockdown, people were very frightened, they were very anxious, they really wanted some answers, and there was a lot of unfiltered information coming forward, and they really, really needed to be able to get high quality information quickly. And it was also very clear that misinformation was spreading very quickly and could actually be deadly. And so after kind of being a bit of an appalled observer on various forms of social media for a while, I decided that one thing I can do is enter the fray and start to provide information, because I'd been spending 40 to 60 hours a week, in addition to my usual job, putting together reliable information, at least to the best of our current knowledge. And so that actually resulted in quite a snowballing effect. Once people are willing to speak to the media tells the media, and you get a lot more requests. And so our communications person in the Department of Medicine sent me a list, and I've done over 700 media pieces since March, which is not really one of my life goals. I'm actually kind of an introvert and I can't stand watching or listening to myself. And yet I think that because I just came in with the information I'd been looking at and tried to represent it as realistically as possible, I'm hoping that that was perceived as valuable. And so the theme of, I think, this relevance to the university is that it really pointed out to me how crucial universities are in a community as a potentially reliable source of information, as a way to distill what's going on and make meaning of it. And although in academia, we tend to actually answer things to our own scholarly satisfaction and move on, I'm starting to think that really our responsibility doesn't end until we get that information into the hands of other people in the community in an accessible way. And especially now during the pandemic, that is incredibly important. I think that the main challenges that I was perceiving as we kind of worked through this pandemic together was there was some difficulty with people appreciating the way science works. Usually in science, ideas come forward, people poke at them and prod at them, and they go back and forth, and eventually it becomes clear that this is actually the truth. Whereas in COVID times, what would happen is a new paper would come out, the headline would be shared widely, it would be interpreted as the new truth that erased all prior papers on the topic, and it would appear actually like flip-flopping of information rather than building a body of knowledge. And that was really hard for trust. There's a lot of silos and echo chambers where people would get information that would be amplified with a particular, I guess, angle. And that can be very, very pervasive and very, very convincing to people, to the point that if they are then presented with information that contradicts what they actually believe to be true, they will tend to disbelieve it rather than like have an open mind to it. And they will push back against information that contradicts what they thought before. And that's also dangerous, because then you end up with camps and factions of different beliefs, when in fact what we really have is a certain degree of uncertainty and an evolving body of scientific knowledge. Other problems that I perceive are politicization of scientific information, which is apolitical. Data is apolitical, but that's been a real problem. And the final thing I think is experts who are expert in their own domain, but not necessarily expert in the domain that they're speaking to, and the need to collaborate more widely, especially on contentious areas in the science around COVID. So those are some challenges. I think that there's also some really excellent opportunities, because we've had such scientific energy has been brought to the core questions of this virus and this pandemic. And the fact that we already have multiple vaccines in phase 3 trials is truly remarkable. And so the body of knowledge is expanding just amazingly, and it's very impressive. And there was a lot of collaboration along the way, and a lot of really interesting groups were formed to help forward that work. I think that the other really excellent opportunities have been in, I mean, for me personally anyway, even though I think that it seems like engaging too much with media might appear unseemly in academic circles, to me it actually really shows a lot of value, both from the side of showing the relevance of academia to the community, because the community supports us and we should support them. But in fact, also the opportunity to, calm anxiety, to reach out, to actually understand what people are experiencing. And I think that those are very, very valuable experiences that will actually help me as a physician and as someone who's trying to be a science communicator. I think the final things that I've been thinking about more recently, as we kind of come through the sprint stage and we're moving into the marathon, is making sure that we engage with communities in ways that will help us build knowledge. And I'm also interested in misinformation and the spread of misinformation and how best to communicate, because people were very, very hungry for information. And I think making sure that we give them the best possible information and be able to adequately communicate risk and uncertainty is a very challenging task. And I think these are fascinating areas. And I think they're actually very crucial, because it's possible that this might not be our last pandemic. And unfortunately, there's a fair amount of pandemic left. And so any work that we can do to refine how we communicate risk, how we communicate science, how we increase scientific literacy, so that people don't see flip-flopping, they see evolution of knowledge, and they see differing interpretations of the same knowledge base, are all incredibly valuable places to go. And this is really, I think, at the intersection of universities and communities. And so if I was going to give an overall theme to my work right now, I think that what I've really been perceiving is that the role of the university and of academia really has to become more permeable at that interface. And we have to engage more with communities, and actually engage more even within our scientific communities, to get the best answers to questions. Our work on the scientific advisory group occasionally got very, very heated in terms of debate. And I think it actually improved the quality of our recommendations, which have been standing the test of time very well. And I think that interaction also has become very, very important. So within academia and actually at the interface with community is, I think, where a lot of the work will become very valuable. And it will also help my colleagues who are doing excellent primary research work in terms of, reaching out to the community and sharing that information as well. So I'm actually going to wrap it up there, because I know that we have a lot of questions to get to, and I spent a lot of time answering questions. So I want to make sure we leave enough time for that.
So Lawrence Richer here. First, a heartfelt thank you to the panelists. And if I could ask all the panelists to turn your videos on. Dr. Terrell and Esther Brooks, if you could turn your videos on, that'd be great. So thank you for that. And so first, a heartfelt thank you from me, and then I think on behalf of the audience. You've really given us a window on how world-class researchers and academic clinicians like yourselves from a variety of disciplines at the U of A are working towards a better and future for both the local community and the world. Just for this reminder for the audience, we'll spend about 30 minutes on this moderated session, but we will be answering Q&As after that. So I'm just going to set the stage. It's been about 8 months since the first case of COVID-19 in Canada, and they're now just shy of 150,000 confirmed cases. Early on, the virus really affected older populations at a much higher rate, but more recently, we've seen younger populations increasingly affected. In Alberta, we've observed a shift from the south to the north, in particular in rural communities. Many of our kids have now returned to school, and our Prime Minister today warned us that the pandemic may be worse this fall. And we've heard about great hope for the future through research, but it sounds like, while there is great hope, we'll be living with this virus for a while. So we've learned a lot in this time, and in no small way, your efforts in research and academic clinical work and advising AHS. I wanted to pursue 3 broad themes with you. Living with the virus, hope for the future in treatments and vaccines, and how in surviving this pandemic, we will hopefully become a better, more equitable society for people of all ages and capacity. So I'll be directing questions to one of you at a time, but please chime in anytime you like. Just don't interrupt the panelist who's speaking. So I'm going to start with you, Dean. I'm going to avoid the doctor nomenclature if that's okay with everyone. Dean, I was intrigued by your comments about how the Indigenous community really came together in this public health response. And maybe if you could unpack it a bit more for us, what could the rest of the province and the world learn from them?
Yeah, thanks, Lawrence. I think there's a couple things. You know, they do have very strong public health units that are always ready to go. If you look at influenza vaccination, it's the highest rates in the province are always within First Nations communities. You know, they take a public health approach to most of their approach to health. And a couple of things that they really realized very early, you know, maybe more so than the rest of the scientific community, was protecting their elders. And so they, you know, built programs initially to really rally around their elders. So they had self-isolation centers set up so that, you know, young members didn't have to go home and spend time with the elders and potentially spread COVID-19. They set up the food deliveries, which is a really impactful program within the communities. So people didn't have to go out and about because, you know, these communities don't have a lot of resources. And so they made sure that they brought in the food to the people who needed it. Same with their medicine, all those types of things. So from my perspective, it wasn't that they did a whole lot of things different. They just did it really well in terms of a well-oiled machine, so to speak, to really, you know, rally around their community and to keep people, for lack of a better term, locked down to try to prevent the COVID spread within their communities.
Thanks, Dean. Any of the other panelists want to weigh in on that question?
Well, I think it actually illustrates the importance of a coordinated response. And I mean, because when we've seen places that have struggled, it's places where it's not the inability to see what needs to be done, it's the inability to actually do it. And I think that just seems like a really excellent response, because it's definitely a challenge, and definitely it would be a community that would have been considered at very high risk and managed to dodge that bullet remarkably well.
And
Lenora, I'm going to ask you the next question. We've just sent our kids back to school, and a lot of people are worried. And I'm wondering what advice, knowing that you've worked hard on communication and distilling through the myriad of mistruths and shifts in opinions that we've observed in the media. What advice do you give parents who have children returning to school?
Well, we did a very extensive review of the literature, which we completed actually, I guess we didn't really complete it until August. It was down the wire. And the reasons that it is somewhat reasonable to open schools really do pertain to the fact that children have very, very low rates of severe illness themselves. They do have a higher rate of asymptomatic infection. If they do get sick, they don't tend to get terribly sick. That might be because of pre-existing cross immunity from other coronaviruses. We're not exactly sure yet, but that's a possibility. And they also, interestingly, even during lockdown, did not appear to spread infection as much as adults, possibly related to severity of infection, because people who have more severe symptoms would spread more. So all of those things mean that children are not as at risk as you would guess of this respiratory viral infection, because frankly, usually they're the plague rats of the respiratory viral infections and they spread them very, very well. But this one, it did appear to be different based on existing data. And then the other piece, I guess, is appreciating the downsides of not going to school and looking for evidence that opening schools might alter community transmission for the worse. So there's a fair amount of evidence that not going to school can have effects on children. It's like social, developmental, educational, but also food security in some instances, safety in some instances. Not having a safe place at home is an issue for some children. And so the groups that are most disadvantaged by school closures are actually the groups that are starting off more disadvantaged already. And then the final piece was, is there any evidence that opening schools would necessarily make the community transmission worse? Like, would we see worse community transmission? And to be honest, most of the models suggest that that's not likely to be the case, but it's not entirely ruled out. So we do have to watch that carefully, and models are models. You know, you can't do that much with them. Having said that, though, we also have to be attentive to who the children interact with. So if there's people at risk in the home or people at risk in the bubble, that might impact your decision around the safety of school as well. So it's actually very individualized risk assessments for schools. And so far, what we're seeing is what we expected, which is schools reflect the risks of the community. And if the community has a lot of transmission, we will find cases in the school. We are hoping not to see severe illness in children. I imagine at some point we will see some, but you know, the odds are in our favor there. And then the final question is there going to be transmission in the school environment with current measures, and how do we determine what measures really must be set? And that's a piece in evolution right now, because we don't have enough evidence around individual pieces of prevention to be able to demand things in a certain way at this point, but we do have to collect information, and we do have to stay very alert to changes in knowledge that would make us change the school plans, because it's been tremendously stressful for people, and it's going to be a fall of much upheaval with kids being quarantined and going back and being home from work to look after your kids, and it's going to be very difficult. There's no doubt about it. But at the time, you can flip it two ways. One is I'm not sure how many schools now, maybe 60 or more schools that have had cases. A handful have had some transmission. I don't think there's been any large scale transmission. That means there's a lot of schools that are running. So it's going to be a bit of a knife edge to walk for the rest of the fall. And I'm not sure what actually is going to happen, to be honest.
Thanks for that, Nora. Anyone else on the panel on that question? Carol, you've outlined in your presentation how you, and have observed in your research, how pandemic with COVID-19 has shown a light on long-term care of a system that wasn't broken by COVID, but was in some ways in trouble prior to COVID. You mentioned the report. I wanted to hear from you and to expand on what one or two things need to be done to improve the care of older populations, particularly those in long-term care.
Oh, you're muted.
You're on mute, Carol.
You think after 7 months I'd have this down pat. So that's hard because there aren't one or two things, but if I was forced to pick one or two things, let's say, we've got to deal with the workforce. We've got we've got to immediately lift their wages and give them benefits and deal with the unintended consequences of one worksite policies. Many jurisdictions didn't even know how many carries were working more than one job before the pandemic hit. We have to look at educational standards. So they're taking care of the most complex people in the system, I would argue, with the least amount of education. So this is the workforce. Maybe everyone doesn't understand the workforce in long-term care. It's 95% women. 90% of the care is given by this unregulated workforce that may have from weeks to months of training. Half of them in urban centers are immigrant women who don't have English as a first language. They are often supporting aging parents as well as have kids in school. And they're working with an increasingly complex resident population. So even if you don't cut the staff, if you keep raising the complexity of the residents, you create a net deficit over time. So they were barely getting by when it hit. So we've got to deal with that. So part of how we're dealing with it in some areas is lifting wages, looking at full-time employment, looking at benefits. And I was very encouraged. I mean, the proof will be in the pudding, but I was encouraged by the throne speech, which talked about national standards, and that should include educational standards. Different jurisdictions have different standards with respect to education. Continuing education should be part of it. And this is harder to do. The frontline workforce is spending 90% of the time with residents. So they're really important to their well-being. They form relationships and they see them physically and emotionally and mentally regularly, but they're really not very engaged in decision-making or places where there are conferences and rounds. So we've got to really begin to think about why we're doing that and how we engage that workforce. I mean, they're the warriors on the front line. They don't abandon their posts, which happened in the early days in some of the worst centers in central Canada, because they don't care about these residents. For a care aide to abandon their posts, they have to be overwhelmed beyond anything most people on this webinar can imagine. And so I have a lot of time for them. And so that's where we decided as a group and individually, we believe we have to start, but it's just where we start. But it's probably the most important thing we can do. And of course, you can't really start there if you don't look at our attitudes toward the aging and our attitudes towards women and immigrant women and the work of caregiving, which is undervalued in any society, in high income society, whether it's caring for the aged or caring for children. And it's easy if it's just like, how hard can it be to look after old people with dementia? You know, you're bathing them and you're feeding them. I mean, how hard can that be? It's actually really complex work, and to do it well and support quality of life takes a lot of skill and tenacity and strength. So I'm hoping that if anything comes good out of this pandemic, that one of the things is that we gain a different appreciation for what's required, and we stop thinking that just because people are in nursing homes, they're out of sight and out of mind, and we don't have to think about it, because the older adult in the nursing home has no voice. And even if they have families who are dutifully coming in and helping with care, chances are they're too exhausted to be politically active and advocate. They're just trying to survive, especially if they're still working and raising kids and stuff. And even if they're not, because the average caregiver person with dementia in Canada is female, and she's 83 and she's called a wife. I mean, there's this, we often have the old looking after the old. So I think we've got to examine attitudes, and immediately we've got to look at the workforce. And the workforce thing doesn't require a whole big philosophical discussion. There's just a list of things we need to start doing.
Thank you, Carol. Lauren, I'm going to turn to you. My daughter attended first day of junior high not too long ago. With the cohorting, she had to sit in her chair the entire day and was quite disturbed at how much her behind hurt. And she walked up to my office, because I was working from home, and said, Dad, I hope you and your colleagues are working on a vaccine soon. And I said, well, I know a few people. But can you tell us what it is about vaccines. Maybe just a little bit about the different types of vaccines and the chances that one or more of these may be effective in helping us with the COVID-19 pandemic, hopefully in the near future.
Well, thank you very much for the question. Let me begin by saying that the work on the vaccine task force has been educational as well as trying to be an expert panel and giving good advice. There are a number of ways that vaccines can be produced. I think but what is unique in this pandemic is we're seeing some very new methods of producing vaccines. And the advantage of these new methods is that they can be done quicker, and we think we can bring vaccines to patients faster than we have in the past. The vaccines, the first one off the market probably will be vaccines that consist of messenger RNA for key proteins in the virus. And this is a Moderna vaccine and a Pfizer vaccine that have been produced in this way that are very effective at producing good antibody levels, neutralizing antibody levels, and in some we're seeing higher antibody levels to neutralize the virus than we see in patients that have recovered from the disease. Another way that vaccines are being produced is that we use a virus, another virus that's not a serious virus for the patient, but we can clone in a gene into that virus that will produce a good immune response to a key protein in the virus. In the case of COVID-19, most of these are carrying the spike protein, and if you get antibodies to the spike protein, you've got good neutralization. We also have a self-replicating RNA that is coming out that even requires a smaller amount, but the RNA will replicate itself for up to 7 to 10 days, a limited span of time, but a time to produce a very good antigen and a good immune response. I'm very optimistic that we will see one of these vaccines or more than one of these vaccines being highly effective. What we are seeing is such a rapid development of new vaccines. This normally takes 6 to 8 or 10 years to create a vaccine and make sure that everything is done. And we're seeing with new technologies, we're hoping this is going to happen within 1 to 2 years. And I think we're well on the way. We have 30 vaccines that are in phase 3 studies. Each of those studies will have 30,000 patients. And I just want to emphasize again how important it will be to make sure these vaccines are very safe. And I think that's the emphasis. Also, that they're very effective. We don't know exactly how effective they will be, but we want to see at least 70% protection with a new vaccine. And there was a question on how much do we need to get herd immunity? We don't know exactly how many people will have to be vaccinated or infected till we got enough immune response in the population that we can say that there will be a marked decrease in the spread of this virus. But herd immunity is very important. And it illustrates the point, to get herd immunity, there's 2 reasons a patient should take or someone should take the vaccine. Number 1 is the vaccine may protect you, but by getting protected, you're increasing the herd immunity. So one of the concerns we really have is vaccine hesitancy. There's 2 types of people that will not take the vaccine: the anti-vaxxers, who do not listen to the scientific evidence and will simply refuse to take a vaccine. And I don't think we'll spend a lot of time trying to convince them. But there's also the people that are vaccine hesitant. And that's why we have to be absolutely base this on science, effectiveness of the vaccine, the safety of the vaccine, so that we get a good uptake in the vaccine, so we can get life back towards normal.
Carol, will residents of long-term care facilities benefit from a vaccine? You're on mute, Carol. Carol, you're on mute.
Absolutely, Lawrence. Long-term care is used to vaccination. Every year, most of the residents are given an influenza vaccine, and most of the staff are. because of they're at such high risk. Their immune systems aren't as strong as they used to be, and they're living in these buildings that weren't meant to help prevent infection. You know, some of the older ones are from the 50s and 60s, and they've got 4 bedrooms and on, and there's communal dining and all those sorts of things. But to the vaccine thing, for anybody who's hesitant, it's not just, as Lauren said, it's not just about us. If you're going to visit your mom or your grandmother or your spouse in a nursing home and you're not vaccinated, you increase the risk to them so dramatically. So it's just so important I didn't used to get regular influenza vaccine, but by gosh, the 10 years my mother lived in facilities, I was religious about it because I was so worried, because it's not a nice death, influenza, nor is COVID. It's pretty horrible. And we've got these, we've had these lockdown policies we have to reevaluate, because isolating an older adult with dementia is a pretty horrible thing to do. So yeah, vaccines are super important in long-term care. It's one of the first lines of defense.
So Lenora, I mean, it sounds like communication is going to be a big, really important aspect of the success of any vaccine, and the acceptance by it of the public. What are your thoughts?
You know, it's interesting because vaccines have always had pretty much the highest bar of safety of almost anything we do. Like they really have. In public health, if you look at the interventions that we do, vaccines have the highest bar to clear and always have been. And I think that's appropriate, honestly, because as has been pointed out, we're giving them to healthy people. So I think that one of the things that people worry about is whether the accelerated development might be a downfall. And so in addition to what Dr. Terrell said, I think some of the points that we have to make sure we bring forward are that, you know, there's some novel vaccines here. And actually some of them were not that novel. Some of them were started in response to the SARS 2004 and the Middle Eastern respiratory syndrome coronaviruses. And so there was a good base with some of the work on those viruses that has helped catapult some of the vaccines forward. There's also been some developments in other types of vaccines that have been, you know, in development long enough that there's experience, but they hadn't made it all the way through to market yet, like mRNA vaccines, for example. And I think that, you know, novel things are concerning to people, but assuring them of the process, assuring them of the standards. And the other thing that makes COVID very different is many vaccine preventable diseases do not happen that frequently. And so to have a trial for them takes many, many years to recruit enough people and then follow them to see if they're exposed and fall ill. And so vaccine trials characteristically are really long time horizon. But COVID, we have over 30 million cases in the world already, with explosive epidemics, with many thousands of cases occurring per day. That really shortens the time for us to be able to test the vaccine for efficacy. And it will also mean that we have to be very careful when we monitor for vaccine side effects as it rolls out across the globe. But I think that if we're clear about the process not being a shortcut, that we're clear about the reasons why we can do this more quickly than we usually can, and honestly, just clear and transparent about the risk benefit and as we know them, and a commitment to adjust if we find out things different. I think that that's very reasonable. And to be honest, although people who are concerned about vaccines get an awful lot of airtime in the media, I think actually, and there's a little bit of research already that most people are very open to the idea of the vaccine, and most people see this as a ticket towards a more normal existence again. And I actually am less pessimistic about the vaccine hesitancy in some ways, because I think it's a smaller group that has a very loud voice. So we just have to flood the market with good information. I think we'll be okay.
So Dean, I looked at a heat map this morning in the news, and turns out northern Alberta is a hot spot in the country, along with urban centers, for active cases. I'm going to pick on your epidemiologic knowledge and take you outside of your comfort zone. What's going on? What's happening that we've seen this shift?
I think the thing that's happening in both populations, both, you know, let's say the urban centers as well as the northern communities, is that you're seeing a real mobilization of the younger individuals. You know, they've they bought into the approach to COVID in terms of how we tried to manage it, but they're just getting mobile now. And particularly for some of these First Nations communities, you know, I've heard many stories of you know, they're having a real difficulty with that 20 to 30 age group, you know, staying locked down and staying in their communities. And I think that's what you're starting to see is some of this mobilization of that younger population. There's definitely been a clear shift of who's getting infected over the last, you know, several months from, you know, initially more elderly individuals to now a more younger population. And I think that's partly what we're seeing is just this mobilization. The borders have started to open up in a lot of these First Nations communities. You know, I talked about it, many of these communities actually shut the borders down. They weren't allowing individuals in or out of the communities to try to keep COVID-19 out of their communities. And with the border opening, I just think there's more mobilization, and you're starting to see it come into those communities. And, you know, they are a marginalized population, and we know that once it gets in there, it's much harder to control because of just their economics or, you know, some of the other things that's going on within their communities. So I think it's a combination of all those.
Any of the other panelists?
So
Lauren, you're on mute. There you go.
I was going to say, I think there obviously is some COVID-19 exhaustion and the isolation, and it's affected more the younger people, as you might expect. And I think that fits what we're seeing.
So we've seen, Lauren, and maybe you want to help us understand this to the degree that we know some people get more sick than others. And we know that age has certainly been a factor. It isn't the only factor, but it's one of the factors. What do you see on the horizon in terms of new treatments for those who do become critically ill or require hospitalization with COVID-19? Where do you see antivirals playing a role in treatment in the near term?
Yeah, I'm happy to respond to this question because I believe that we've seen antivirals do some remarkable things in HIV and hepatitis C, but these are chronic illnesses. And when you use an antiviral, you've got a timeline to change the pattern of the disease. In COVID-19, it's a rapidly developing disease. And I think what we need good antivirals for is to change the course of the disease. It starts out with a respiratory infection, but it can progress, some of them very mild, as you mentioned, and it varies biologically in different people, and there's other factors, age, comorbidity, etc. However, I believe if we had very good antivirals and we used them earlier in the disease, you would change the course of the disease in many patients. I think that one of the very best drugs we see to inhibit the virus is remdesivir. Remdesivir in the first clinical trials were rather disappointing. You could see how the antiviral has a wonderful effect inhibiting the virus, but not having that same effect in the patients. And much of the time in the beginning was used in patients and late in the disease. And if you look at another common virus that many people can understand is shingles. It's a reactivation of the chickenpox virus. And when it breaks out in a dermatome or skin, if you get it early with the appropriate antivirals, you can modify that course of the disease and change it dramatically, and also decrease the post-shingles complications of prolonged pain. But if you wait until it's been going, more established, then the antivirals have a harder time, particularly in acute disease. And the later stages of this disease are mainly mediated by immunopathological effects, the immune system reacting to the virus and also causing the immune system overreacting and causing serious disease. And at that stage, your antivirals do not work as well. And that's where the dexamethasone has been the one agent at that later stage that has shown the benefits. I believe one day we'll have very good, I would just say, I'm concerned that this virus will continue to circulate. We've seen this with other coronaviruses. There's 4 other coronaviruses that cause the common cold. We're able to control SARS, One, we were able to control MERS. By the way, there were some vaccines developed, as Lenore mentioned, but the disease disappeared and they're not developed because nobody can make money with it if it's not going to be circulating. So many different factors in here, but I think the key will be early diagnosis and recognizing the disease and starting people on an antiviral that's very effective early and changing the outcome of the disease in the long run if it continues to circulate.
So, Carol, I wanted to pick up on, I think, a comment you made that I'll sort of characterize as isolation. You know, the need to limit the spread of the disease has rendered many individuals with in long-term care facilities quite isolated, and certainly observed it in my own practice where in pediatrics, caregivers are not allowed to be with their children. And so maybe if you just expand on that and what impact that has had on the health of persons in facilities.
Thanks, Lawrence. None of us do well if we're completely isolated. And typically the older adult in a nursing home has got dementia, and they've also got hearing loss and vision issues and comprehension issues. So then you dress up the staff in masks and gowns and hoods, and they can't just plainly hear as well and see as well. They can't recognize familiar faces if they're there. And people with dementia often have a lot of anxiety and fear. And some types of dementia will result in other manifestations like hallucinations and paranoia and things, but that's not necessarily the majority. So they're now in a highly vulnerable position. We're not letting their families in. They can't see the staff. They can't hear them well. And they don't go to the dining room because we're keeping them in their rooms. And we won't let, for a while, we weren't letting animals in. We weren't letting any visitors in. We were feeding them in the trays. You put an old person in a bed for 3 days and then show me that they're ever going to walk again. So before the pandemic, we had 70% of people in nursing homes in wheelchairs, which we normalized. It's not necessary, but there's a bunch of reasons for it. It's worse now because we've put people in bed and kept them there, and the muscle wasting is just so profound. I have asked many people, and I mean, maybe it's not a fair question, but I've yet to hear a report of a palliative care unit where they refused to let family in, and I've yet to hear a report of a dying child who was refused his parents. So clearly there's some risk, but clearly we can manage visitors. We have to be careful, we have to be thoughtful, and they have to use protective equipment and follow the rules. But why it's been okay for old people to be isolated like that when other people haven't had to be is beyond me. I understand initially there was a lot of fear and the barn was on fire, and we got fire trucks and fire extinguishers and we're trying to put it out. But this went on for a long time in some jurisdictions. It's different. I mean, each province has got some differences, and regions within provinces are different. And many places opened up quicker than others. But this is the thing I hear most from families that's distressing to them. I mean, I just can't imagine if your spouse is in long-term care and you can't visit them for 4 months and they're dying and you can't go in. This is like, I can't even imagine that. I mean, I was struck the day I knew we were in trouble, the day I watched the tree people, you know, the arborists, they wheeled up a arborist truck with a bucket and wheeled it up a woman to the 3rd floor of a nursing home in Ontario so she could see her mother through the window. And I thought, my Lord, that's the best we can do. So I think we really have to think about this. Like, we don't live our lives without risk. And one of the problems in nursing homes is that they can be so risk aversive, and sometimes families are the most risk aversive. We have to accept a reasonable, cautious amount of risk and put the right things in place, because it's really bad for older adults to be isolated. It's one of the worst things you can do to an older adult with dementia. And just the existential suffering, most of us would, if we filled out a survey, would probably score really highly on our fear of dying alone. So it's a problem. It's being addressed better in some regions and areas than others, but we're not all the way there yet. And, you know, we heard the Prime Minister talk about we're in the 2nd wave. whether we are or not isn't really so much issue as the fact that whatever we call it is that we've got more cases, and there's a lot of fear that we'll react with that same aggressiveness. Because, you know, once, I mean, you can understand it. Once it's in a nursing home, it's not as, it doesn't spread as easily now as it did because there's so many more precautions. But, you know, lots of nursing homes didn't have enough cleaning staff,
Yeah.
for heaven's sake. So it's a big issue. It's a real sore spot with families, and it should be. And it's a real, it's one of the major things that facilities and directors and staff have to deal with.
We're going to turn over to the Q&A here, but I'm going to ask one more question. University and university students have been impacted by COVID-19, and the University of Alberta still does not have students. The campus is beautiful, but it was alarming to see how quiet it was when I walked through it yesterday. I think it's probably fair to say none of us on this panel were university students in this millennia, and nor did any of us go through this. What advice do you have for a university student today going through something like this? Lenora.
Well, I actually start by saying, like, sorry, because, you know, with the students who are finishing high school or transitioning from one school to another, you know, major life events that have certain, you know, ceremonies attached to them have been disrupted. And although, I mean, compared to some other places on the planet, we've done very, very well, those are still important. And it's still unfortunate, and it's still not really fair. And so that is, you know, the reality that we're in. So the other thing that I think I'm very impressed with, though, is the adaptability of students of all ages. Like, they're amazing, they're fantastic, and people are figuring out how to make it work. One thing I think we do have to be sensitive to for students is that not everyone can do well in an online learning environment. And so it may be the case that we have to figure out flexible ways to have some safe interpersonal, safer, I guess, like what is safe now, but some interpersonal venues that offer a little bit of a different kind of a learning engagement style for students. Because I think, you know, we can manage and say everything can be done online, but at the end of the day, I'm not sure everything can really be done online. And in health sciences, we know that's true, and we're pushing a lot of stuff back to the eventual return to the wards for more experiential learning. But I actually think that the adaptability and the willingness to go with the flow and trying not to be a spectator in your education, but to actually take the opportunities you can to engage with your education is very important. And it's really it's like a huge challenge. And I really feel for the students, but at the same time, I'm also amazingly impressed by how well they actually seem to be doing so far.
Great response. So thank you, Lenora, and thank you for allowing me to ask it. So I'm going to shift to the Q&A, and we have a number of questions lined up, and maybe I'll start with the first one. At the top of my list is from Christina Krylova, and I'll ask it to all of you, but maybe Dean in particular. So what do you think of the government's response to COVID so far? And with the second wave announced by the Prime Minister tonight, how do you think the second wave would be in the upcoming fall/winter months, and how long do you think it will last?
If I knew the answer to those, I wouldn't probably be sitting here. I'd be somewhere else, I'm sure. You know, I'm not sure we're in a second wave yet. I think that's a media term that gets used a lot. We're definitely in some type of transition where we are starting to see a higher plateau of cases for sure in Alberta than we did over the summer. And I think what happens over the next month really depends on what our behaviors are over the next week or two. That's really going to dictate, I think, where we go. You know, was our response adequate? I think with the information that we had, I think they did a reasonable job. Sure, you can always look back, and 2020 hindsight looks great. But, you know, many countries followed, have done what Canada has done. Other countries, as Sweden, didn't follow our model. Are they any better off? I think you could have a great debate about that. And, you know, they've had some successes, but they've also had some real letdowns as well. So, you know, moving forward, I think Lenora said it best in her talk, where this is not a sprint. This is going to be a marathon. And I think people have to try to adapt and start to think about the new normal until Dr. Terrell gets his vaccine on the market for us. Because I don't think it's going to disappear overnight. You know, I think the winter could be, it could be problematic in certain areas. I think we'll have outbreaks, expect cases, but people have been very resilient, and I think they'll get through this just like we have, you know, from the spring and the summer, and I think we just keep moving forward.
Next question from Kathy Trepanier. I understand reputable studies have shown that there have been no or few cases of transmission of COVID-19 on airline flights, and this is linked in part to the air exchange, Q3 minutes, and HEPA filters. Is anyone looking at future recommendations for air exchange in high-risk settings like long-term care facilities? Lenora.
I can take that one because I've done a lot of thinking and question answering about planes. We also did a review of heating, ventilation, and air conditioning systems, and we're just re-reviewing the literature that supports the 1 or 2 meter distancing things in recommendations for public health. So first of all, planes, yes, the air exchanges are good. There's laminar flow essentially from the center of the cabin towards the window seat. So really on a plane, most of the risk actually in modern planes, as long as they have that system, which most do, is to the people immediately next to you. And there's much less risk as you get farther away. So the people right next to you and in front and behind you are at some risk, not terribly high. But there's also risk, of course, from fomite transmission. If you are, like if a person who's infected is the first person to use the bathroom and rubs their nose and grabs the doorknob, well, there might be a problem there. So there's nothing that's really absolute. And the other issue, of course, is the pinch points that you might experience as you try to get on a plane and off in a plane without coming into close contact. But planes, you're quite right, the actual air environment is fairly safe. And there's a lot of interest in how much the airflow might impact risk in built environments. There is very little direct data. There's a lot of droplet and aerodynamic data, which would tend to suggest that optimizing the HVAC systems should reduce infection risk. But there's very little actual direct clinically relevant data that proves that. So it's all still fairly theoretic. And if we want to do a twofer, I think I saw another question about aerosol transmission at the bottom.
Mm-hmm.
Maybe it's gone. But it was basically getting to this idea of the classic teaching within medicine is to use the idea of airborne or aerosol transmission as shorthand, basically for risk that is mitigated by an N95 mask of pathogens that tend to be much more highly infectious, where your airspace could remain dangerous to others for some hours, is kind of the shorthand for airborne aerosol transmission. When in actual fact, the word aerosol really just means particles in a gas. And everything that we're talking about is aerosols of different sizes. And so there probably is some lack of finesse to using that definition. And there's a bit of a worlds collide when people start arguing about it, when they were actually saying the same thing with different terminology. And it was kind of interesting to see how that unfolded in the media. But I think that we are going to see increasing amounts of information about the relative role of small droplet, longer range spread, and on the role of, you know, environmental conditions, particularly HVAC, in reducing spread. And HEPA filtration has some promise, not proven. Higher humidity is good. Open windows are good. Higher air exchanges are good. But the degree to which those would impact your risk beyond the measures that we already know about is so far still fairly unknown, if that's an okay summary.
Great. I'm going to give this one to you, Lauren. Is COVID mutating? And if so, is this going to delay vaccines and antiviral therapies?
Thank you. It's a good question. And we're still doing work on it to see. The virus does mutate. But, you know, it's a large RNA virus. Most RNA viruses are 10,000 nucleotides or shorter, and this one's about 30,000. surprising that you see a virus of this size, RNA virus, that can replicate as well as it does. And the reason it probably has the good stability of the genome is it does have proofreading, which most RNA viruses do not. So the mutation rate in this COVID virus is slower than we see in some other RNA viruses, such as influenza. So I think that from that point of view, we're seeing that we can produce mutations. We can see the slow development of resistance when we artificially try to do this in the lab. But some antiviral agents have a very low resistance and very hard to produce resistance to, such as remdesivir is hard to make resistant virus. So I think that, and the vaccines, I think the vaccines are going to be also quite effective, maybe more effective than for influenza because of that, but we will only know that through the test of time. I noticed that there was a question about, are we seeing true reinfection? And we know that there is occasional cases of reinfection already. And that's bad news, but the good news is that the people who've been reinfected have had much milder in the second infection than they did on the first. And they clear the virus quite rapidly. This may be because you get a good rapid immune response to eliminate the virus. So I don't think we'll see as much problem with the vaccines and long-term immunity as we have with influenza. I hope that's not the case. Thanks.
Thanks, Lauren. Carol, do you think that care for the elderly ought to be included in general health care and be provided by provincial government, or maybe even by the federal government apart from the regular health system?
So
I lost the rest of the question. It jumped off my screen. So
it's an interesting question. A couple of historical things. So there's nothing in the Canada Health Act that says you can't include long-term care. And there's a perception that it can't be. And in fact, in the 80s, we had about 7 years where the federal government included transfers to the provinces specifically dedicated to long-term care. That, and I don't know why that stopped and why it's never come back, probably because it costs money. The problem, I mean, it's clearly a provincial jurisdiction now, although the federal government might have a significant partnership opportunity by using health transfers and accountability structures, but that usually generates a federal provincial jurisdictional argument that is frustrating, to say the least. One of the challenges with having it just be in healthcare is then you treat it like it's a healthcare issue. You treat aging like it's a medical problem. You build nursing homes aren't chronic hospitals. That's not what they are. That's not what they're supposed to be. They're supposed to be homes. They're where you go. They're your last residence before you die. And so if you totally medicalize it, you lose so many aspects of quality of life. So you need a combination of health and social care. In Britain, it's not under health care at all. It's social care, and that has its own challenges. So I think a model that combines health and social care, and I put social care first. You can't have, I would argue, quality of life if quality of care is really bad. And quality of care tends to be the jurisdiction of health. If you got a 4-inch pressure sore, it's pretty hard to have quality of life. So quality of care is a necessary, but it's not sufficient condition. To get quality of life, you've got to have the social aspects of living. So there's not an easy answer to it. I think most provinces that were really committed to this would look at a combined social and health model. But right now, almost everywhere that I'm aware of in Canada, it's considered health, which is kind of strange. Because you know, nursing homes came from they originated in Elizabethan poor law in the 1600s. So they started as almshouses and poorhouses. So they didn't get a good start in the beginning. And they've carried some of that stigma forward with them. But no, I don't think it should be exclusively health, because I think that's too narrow.
I'm going to try to get one, maybe two more questions in. I want to go to you, Lenora. Is there evidence that masking is reducing transmission of COVID?
That depends on who you ask. The masking literature is difficult right now. And as someone who tries to be very objective, I'd have to say that most of it is inconclusive. There's pretty good droplet data that masks, even not very good quality cloth masks, can reduce the amount of virus that a person, or droplets that a person might expel. But because transmission is a very complex event and there's different amounts of virus and different respiratory secretions, and the distance that virus travels within a droplet is not necessarily fully known. And the actual impact of mask mandates has been, I'd say in ecologic studies, kind of mixed, honestly, at best. That we don't really know the degree to which masks will reduce transmission yet. It is plausible that they reduce transmission. The degree of reduction that they add is something I think we would really like to be able to say with more clarity, because that would help us prioritize our interventions, because I really think layered interventions are important. So reduce your contact numbers, keep your distance, wash your hands frequently and wear a mask as directed are all very important components. But the prioritization piece is something that we're really looking for better guidance on. I would say that if the mask data were better than it is, we would have seen public health-based national mandates. Instead, we see a patchwork of local mandates based on individuals interpreting the same knowledge base in different ways with different angles. And so it remains a bit controversial. There is supposed to be an RCT of mask wearing. In this case, it was masks to protect the wearers, so it's not masks as source control, from Denmark, that was completed enrollment actually in June and was supposed to be reported in August, and it remains unreported. So I'm wondering about that. However, I don't think that's going to answer everything, because the other piece is we are really wanting the mask to protect others from the unwittingly infected self, and we do not yet know how well that works. Certainly, if you use your mask poorly, or if you touch your mask and then touch other things without cleaning your hands, they might not actually help the situation. So proper mask use is also important.
So I got time for one more, and I apologize, Dean. I haven't directed many questions your way.
That's fine by me.
It's fine by you.
The real experts.
This one caught my eye, and I'm gonna give Dr. Terrell the last word. Every nonprofit and university and research center is asking for financial support in COVID-19. Why should I support the U of A? You're on mute, Dr. Terrell.
I think that you look for where good quality science is being done, and the only solution to severe problems is research. And I would include basic discovery research. And I believe that basic discovery research is what transforms healthcare systems. If you look at the AIDS example, when I started to see AIDS patients, none of them survived more than 2 years. Today, they have a life expectancy that's near normal. And that's because of the research that's gone in at the very basic level to work out the structures and develop compounds and how they can uniquely change the outcome of an infection. I think you can say the same thing with HIV for hepatitis C as examples. But, when you think of I ask this question often, who do you think won the Nobel Prize for the development of polio vaccine? Was it Salk or was it Sabin? And the answer is really neither. Enders and other workers working on the way to grow cells in culture led to the development of a vaccine that eliminated polio. So I believe that investment in research is, and if you look at the economics of it, it's one of the most important investments we could ever have. If you look at COVID, not COVID, but SARS-1, we had some vaccines that were working. However, that investment in that research dried up because the disease disappeared quickly. I want to point out that public health is one of the most important things we could have. You can see the economic and the social and the disruption because we have a problem with a major virus like this. You wonder how a small piece of RNA could bring the world to its knees. And it's key that you keep funding research so that we, even in the times the diseases aren't there in such prominence as now, because we need to be prepared And this is a good place to put your money in universities or in science institutes where there is top-notch science will, in the long run, pay the best dividends.
So with that, we're at the 8:30 mark. Thank you all very much, panelists, and thank you to the audience for bearing with us. And I guess I'll turn it over to Colleen for the last word. Is that right, Colleen?
Yes, that's correct. So I do want to thank each and every one of you for giving us your time, not just tonight, but in preparation for tonight's presentation. Really fascinating conversation and full conversation too, covering social issues, health issues, science, communications, all of it. So thank you so much for your thoughtful input for our audience tonight. And to our audience, several questions still are unanswered in our box, but our panelists have actually asked for those questions. So we're going to share those with them after the event. And I can't guarantee that they will write to you personally, but I'm sure some of their assistants and other staff members will be able to engage with you in your questions. So I do also want to point out that the University of Alberta has hundreds of researchers working on COVID-19 research, and tonight's panel represents just a fraction of them. If you'd like to learn more about the topics that were covered tonight, or some that we didn't get a chance to talk about, there is a question in the follow-up survey that we'll send out. You can put your questions in there or just specify the area of research that you are interested in. And we're going to divvy that up, and we'll get some of our staff replying to you either with research information, websites, etc., that you can use to investigate these topics more fully. So watch for that survey to come likely tomorrow morning. We also invite you to consider supporting the work that our researchers are conducting, and there will be information on making a donation, considering some research options in that survey as well. I just want to remind you again that we have more programming coming your way during Alumni Weekend. Tomorrow night we feature a presentation by the Reverend Naomi Tutu on truth and reconciliation in a time of crises. You can visit our website there to find out more information and also to watch content on demand. So there will be a recording of this evening's presentation. It should be up there tomorrow, so you can share that link with other people, watch it again, and take part in all of our programming. So once again, thank you so much to our panelists for joining us tonight and sharing your expertise. Be sure to follow us on Instagram and Facebook to get the latest news. And that concludes tonight's presentation. Thank you all so much, and good night.